Now I invite Dr. Duru Shah for her topic on is endometrial receptivity different in PCOS women. Madam Duru Shah does not require any introduction. She is the director of the Center of Women's Health and Infertility, a member of editorial board TOG, Climatary IMS, GREM, ICG, and JHRS. First and only Indian to receive FIGO's Distinguished Merit Award for services towards women's health. Madam, please start.
Thank you very much, chairpersons, ladies and gentlemen. Thank you very much for ISAR inviting me to speak, and I'm happy to give this talk on is endometrial receptivity different in PCOS women? We all know that there is a need for the embryo to implant in the uterus, and that's the function of the uterus. But the endometrium actually does not allow the embryo to implant on any day of the cycle. It's only during the window of implantation, that is in those 2 or 3 days when the endometrium is at its best, that the embryo can implant. And the function of the uterus is actually to keep rejecting it until the endometrium is correctly primed by hormones. Now, if you look at what really is the normal physiology, as we see over here, the ovarian steroid hormones, you produces estrogen in the follicular phase, it acts on the endometrial steroid receptors, creates a proliferative endometrium. At the same time, the corpus luteum secretes progesterone, which acts on this proliferative endometrium and converts it into a secretory endometrium. At the same time, progesterone is also controlling a whole cascade of growth factors and cytokines and creates that window of opportunity. That means that is the time when there's a maternal embryo interface. The embryo comes in touch with the endometrium, tries to find the right space where it can implant, and only then can it implant. So this happens through a huge cascade of secretion of all kinds of proteins and enzymes, and various genetic expression is there, and there is a morphological and ultrastructural changes which have been diagnosed both in ultrasound and in the endocrine, in the genetic expressions. So what really happens in PCO patients? In PCOS patients, it is associated with oligoamenorrhea. It may be having hyperandrogenism, or there may be a polycystic ovarian morphology. But we also know that PCOS is associated with insulin resistance and obesity, which is not included in the diagnosis of PCOS, but yet we know that almost 54% of patients are having are having insulin resistance and obesity. We know we can correct the anovulation by giving ovulation inducing drugs, and we are able to make an anovulatory PCOS woman ovulate. But we also know that the pregnancy rates are low, though 80% may ovulate, but the pregnancy rate remains low. So there is obviously some factor which is coming in the way, which is preventing that embryo, which may be a very good quality embryo, tested for aneuploidy, which we do in IVF. We may test the embryo. If everything is okay and the endometrium looks okay, everything looks okay, but still the embryo may not implant. And what happens in the patient of PCOS is that she's got associated factors. She's got factors like hyperandrogenism, she's got insulin resistance, she's got obesity, she's got all these factors which may be playing a role in this entire situation. In our own experience with 1,000 PCOS women, confirmed PCOS, we have found that there are almost 8% women who have got hypothyroidism, more than 40% having insulin resistance, about 13% having hyperandrogenism. Now, this is all actually measured in the blood. 73% have an ovulation, 55% are either overweight or obese, and almost 50%, 46% are having central obesity, by which we mean the adiposity or the fat is in the intra-abdominal. It's around the liver, it's in the omentum, it's all over. I'm sure when you operate on a patient nowadays, of course, most of us are doing laparoscopic, but when you open the abdomen, sometimes you see the whole intestine bulges out, the omentum comes out, there's fat everywhere, it's very greasy. This is what you call visceral fat, and that's the white fat which is present intra-abdominally, which causes a lot of chronic inflammation. So I'll bring you an example of a patient we had, a similar, so that you understand this better. She was a 38-year-old married woman since 6 years with primary infertility since 3 years. She had undergone 2 cycles of IVF in another clinic, which were unsuccessful. On examination, we found that her BMI was 35.4. She had a waist circumference of 105 centimeters, normal being less than 85. Her ovarian volumes were 13 and 11 ml, though she had an antral follicle count of only 6 to 8 follicles in each ovary, but we still call it polycystic ovarian morphology because if you realize she's 38 years old, the follicles will be less, but the ovarian volume is high. Look at the ovarian volume, it's high. So, this case was diagnosed as a PCOS phenotype A with hypothyroidism, insulin resistance, and obesity. And we got her investigations done. Her FSH was FS7.1, LH 9.6, upper limit being 10. E2 was 96. Now, normal should be anywhere around 40 to 50 on day 2 or 3 of the cycle. It is high. And AMH is 3.0. The fasting sugar, post glucose sugar was fine, but if you look at the insulin, it's 20.6. An average Indian insulin has about not more than 17 MIU per ml, based on a study which we have published. And post glucose insulin, see her post glucose insulin, 421. According to the normal kits, 20 fasting is normal, up to 25 is normal. So if you do only a fasting, you'll completely miss this 421, which happens after glucose. The free androgen index is 14.8, which is less than 10 is normal. Thyroid was 5.1. HOMA IR is 4.5, normal being less than 2.5. HbA1c 6.1. There are many people who are diagnosing diabetes only on the basis of HbA1c, which I think is totally wrong. You need to do a fasting and a post-glucose. So the management of this patient was lifestyle modification, lose weight, eat right. We started her on a small dose of thyroxine 12.5. We gave her metformin 500 3 times a day, and flutamide, which is an anti-androgen, because she had a high FAI of 250 milligram once a day, and we don't give it for more than 3 months, telling her not to get pregnant during that period. So we asked her to use a contraceptive. And then after 3 months of treatment, her thyroid came down to a little normal state, but though women who are planning pregnancy, we prefer their level to be less than 2.5. Fasting sugar 94, post-lunch sugar came down. Both were normal initially too. The serum insulin fasting stuck at 20, but the post-lunch became 12.6. After 3 months, she stopped the flutamide, continued with the treatment, and a total of 6 months later, she had lost 6 kilograms of weight whilst the treatment continued. In the 7th month, we started her treatment after all her hormones became normal. First cycle letrozole with monitoring, and IUI, missed a period, pregnancy positive. What I'm trying to tell you is that you do not need IVF for every patient. You need to correct her hormones, especially in a PCO patient. If she's got no other factor, male factor is normal, everything is normal, and you give ovulation inducing drugs, she's not conceiving, please look at her hormones, correct them before you proceed further. Now, how does this hyperandrogenemia, hyperinsulinemia affect endometrium receptivity? What we know is that when you have high androgens in blood, it is because of the sex hormone binding globulin being low. Sex hormone binding globulin, if it's low, the free androgens will be high in the blood, and that will also give rise to high insulin, and this androgen levels go on increasing in the blood, which then get aromatized in the fat in the body to estrogen. So there is enough estrogen going on anywhere the woman is not ovulating, her proliferative phase is going on, she's got high estrogen, she's got more estrogens coming from the adipose tissue. There's extra amount of estrogen in the endometrium. There's a lot of endometrial changes which take place. There's at the same time less progesterone. There's no decidualization. The window of implantation is affected, and therefore finally there's a reduced endometrial receptivity. This very nice study, a meta-analysis, which was looking at whether metformin is really helping a patient or not, and therefore they wanted to know, is it because of the obesity that she's not conceiving, or is it because of the PCOS itself? So they compared because you see, we also know that whether the PCO woman is thin, she's lean, or she's obese, almost 90% of them are insulin resistant. Don't ever forget that. So even if she's lean, please check on her insulin resistance. And even if you don't want to check, it's fine, but at least maybe if she's not conceiving, think in terms of giving her metformin. Now, this study proves very well. This consisted of 62 studies, including 6,571 patients who were divided into two groups. The first group getting metformin, the second group not getting metformin. And they looked at endometrial thickness, endometrial artery resistance on ultrasound, and they looked at the secondary indicators as clinical pregnancy rate and miscarriage rate. Now, here you see that the patients who were given metformin, how does metformin work? Basically, it improves the transfer of glucose from outside the cell to inside the cell. It doesn't really lower the blood sugar levels, it lowers the insulin levels. And it helps the insulin resistance to become lesser. And therefore, all the changes which occur with insulin resistance reduces. This helps to create better implantation because we know that there are insulin receptors even found in the endometrium. We need to make sure that the insulin sensitivity is good. The glucose enters from the outer cell to the inner cell so that the oxidation inside the cell is better. There's less oxidative stress, there's less hypoxia within the cell, and therefore the insulin works better. Now, coming to the study, same study, what we find is that the endometrial thickness definitely increased statistically significantly. These are total of 1253 participants. The endometrial artery resistance index decreased with metformin. The clinical pregnancy rate increased and the miscarriage rate decreased. So there's enough evidence to show that the metformin works for insulin resistance. And therefore, these studies, what happened is that though they had so many participants, they did lot of other variations. They did metformin with placebo, metformin with clomiphene citrate versus clomiphene citrate, metformin CC treatment after and before. So a lot of variation, and therefore they said there is enough evidence to show that metformin works to reduce the insulin resistance even in those patients who are not obese. Remember this, it's not the obesity causing the insulin resistance, it's the PCOS itself causing insulin resistance, and therefore even lean PCOS deserves to get metformin. So there is a new marker for insulin resistance which has been promoted as adiponectin. Now this is it's a protein hormone which is released from the adipose cells, and these adiponectin levels are normally it's an anti-inflammatory type of a product, hormone which is released from the fat. Now this is normally an anti-inflammatory product, but in PCO patients it is low in the body. So the levels of adiponectin are very low in PCO patients, and therefore we feel that probably adiponectin could be a marker for insulin resistance or hyperandrogenemia both. Now there's a lot of work done on this, but due to lack of time I cannot go into those details. But coming to hyperandrogenism, in animal models it's been shown that when you give testosterone to monkeys and sheep, you will find that there is some amount of ovarian dysfunction which takes place, and therefore they have found that the endometrial alterations which take place in the ovaries, which happens whilst the fetus is in the womb of the mother, this is what is happening, that there are a lot of androgen receptors being formed inside the human fetuses in their endometria, and therefore these children, when they grow up, genetically there is some amount of PCOS transmitted, but if they put on weight and all these lifestyle changes are not taken care of, there's a high risk of them developing PCOS, and these women are born with extra androgen receptors in their uteri, which is causing problems. So there are multiple molecular pathways being confirmed how hyperandrogenism affects endometrial receptivity. These are too complicated even for me to understand. It will be the geneticist, so I'm not going to go through it, but trying to tell you that there's enough evidence to show that androgens which are high in the blood definitely lead to a problem in the window of implantation during implantation failure, and therefore the androgen levels need to be checked and need to be corrected before you start any treatment for infertility. Where obesity is concerned, I think all of us are pretty convinced that weight reduction before attempting pregnancy in overweight and obese PCOS women will definitely to some extent increase pregnancy outcomes. Now, the last thing I want to talk is about gut microbiota, where there's a lot of evidence coming in today that you're born with a certain amount of bacteria in your gut. And it's the lactobacillus which helps to protect you, and they are in millions in number. And they found that children who are born of C-section mothers have a less amount of these lactobacilli in their stomach as compared to normally delivered babies. And in normally delivered babies, if there is vaginal dysbiosis, also it can cause a problem. And therefore, what we find is that when there's high fat and sugar in the diet, in a PCOS patient especially, these gram-negative bacteria produce the free fatty acids, which enter circulation, cause a state of chronic low-grade inflammation, cause activation of immune system, which interferes with the insulin receptor, increases the insulin levels, which increases the androgen levels, and then it leads to PCOS. So if you've got a patient with gut dysbiosis, if she's planning a pregnancy, please correct her gut dysbiosis, because there's a crosstalk between the gut and the vagina, and it has been shown that when you put this gut microbiota of PCOS patients, actually this gut is containing Bacteroides vulgaris, when you transplant the feces of these PCOS patients into recipient mice, you'll find that the mice develop a bad ovarian function, increased insulin resistance, and high androgens. And similarly, in women, it has been shown, and when they are given, this lactobacillus, it has been found that they can relieve their infertility. So there are a lot of experiments in animals, etc., have been done. The last thing is about assessment of endometrial receptivity. We all know how to assess it, both through ultrasound, both through various hysteroscopy, and through uterine natural killer cells. This very good study of an analysis, we have heard of ERA, and this ERA is an analysis of 238 selected genes, and this has been identified the endometrium as whether it's pre-receptive, late receptive, optimal receptive, or post-receptive. Now today many labs, they actually want to transfer, especially if they have had 2-3 implantation failures, they want to make sure the endometrium is the embryo is healthy, so they do a PGTA. They want to make sure the endometrium, they are putting the embryo at the right time. They do a ERA test, and they come to an intention as to which is the right time to transfer the embryo. Though all of us are not convinced about this test, and it has been compared to all the endometrial receptivity markers, not found to be very, very specific and not very sensitive. And therefore, people have started using it in some cases, they go by the ERA test and do only a personalized embryo transfer. But there's a new test which has come, which is being used, still experimental. And this test is a personalized embryo transfer. Just give me a minute, please. Actually, the time was 20 minutes. I don't know why we are giving less time, because our presentations are made for 20 minutes. The note we get is 20 minutes. Thank you. I think Madhuri had the same problem, unfortunately, because of that. So this is a meta-analysis of 11 published studies in the final analysis, divided into good prognosis and poor prognosis. Now, if you see over here, these are total of 11 studies with many patients. Good prognosis patients were the one which was 0 to 2 with prior failed FETs, and where no ERA was done, and the live birth rate was 53.7. And where ERA is done, the live birth rate was less. That means in good prognosis patients, this ERA doesn't really have much of a value. Whilst in the the poor prognosis patients were the ones where more than 2 failed ETs happened. There was recurrent implantation failure, and their ERA was done. If ERA showed non-receptive, then a personalized embryo transfer was done. Means the next cycle, the embryo was transferred according to that window of receptivity. And here in the receptive one, single elective ET was done. And again, it was found that there was not much of a difference between the two. But what the take-home message from this study is that you probably need to do the test only in those patients where there is recurrent implantation failure, where you may find that to some extent the live birth rate compares quite well to the single embryo transfer. Another test is the endometrial, where they are combining chronic infection, they are combining ERA, and they are combining the and the microbiome in the endometrium. All these three tests are being combined and being used, and they've found that the conclusion is that if the woman is aging and if she's got a low amount of microbiota in her endometrium and she's got a pre-receptive endometrium, then it gives you more compact results in terms of talks about chronic endometritis. It also talks about the microbiome, and it talks about the era. So all three together probably giving good results. So my concluding slide is that PCOS is a common disorder leading to infertility, majority due to anovulation, but it's not the only cause. Abnormal levels of hormones and their receptors in the endometrium negatively affect endometrial receptivity. We must rule out gut dysbiosis, chronic infection, and we must improve the embryo implantation. And we must remember that correction of insulin resistance, hyperandrogenemia, obesity, and gut dysbiosis should all be looked into before pushing into a patient with IVF if your routine treatment has not helped a PCOS patient where no other abnormal factors have been found. I would like to use this opportunity to invite you to the International Conference on PCOS through the PCOS Society of India in collaboration with the Androgen Excess and PCOS Society International, and we are going to talk about PCOS, an old story with new tales. We welcome you all to this meeting, which is being held on June 21st to 23rd in Mumbai, and we'll send you all details further. Thank you very much for your kind attention.
Thank you very much, madam,
Sorry,
for the
chairpersons, for
detailed.
taking this time, but when we prepare a lecture, we prepare according to the time duration sent to us. Thank you so much.
Thank you very
Thank-
much for excellent depth.